Hello, I am Senior Resident Markevičiūtė. My supervisors and I would like to present the case, was it the cause or the consequence? 41-year-old woman presented to the Department of Ophthalmology in Lithuanian University of Health Sciences Kaunas Clinics with a month of progressive blurry vision of the left eye in 2018 May. In 2016 April, she had the main surgical procedure, which was followed by 2 more surgeries. From 2018 January to April, she was treated with interferon alpha due to the condition caused by the same pathology. In 2018 April, she felt worsening of the visual acuity of the left eye. The visual acuity of the right eye was 1.0, intraocular pressure was in the normal ranges, and objectively without any pathological changes. The visual acuity of the left eye was 0.2, intraocular pressure was in the normal ranges, media was clear, optic disc without changes, brown-gray, irregular pigmented elevated lesion in the central part of the fundus was observed. The periphery of the fundus was without any changes. So additional systemic treatment was prescribed by a non-ophthalmologist due to the course of the main disease. The patient came for a consultation to ophthalmologist about 1 month after newly prescribed systemic treatment. And we can see positive dynamics. The visual acuity improved from 0.2 to 1.0, and in the left eye fundus, irregular macular pigmentation without elevation was observed. Here we can see the picture of the left eye fundus, and parafoveolar irregular macular pigmentation in the upper temporal quadrant without elevation was observed. In OCT, irregularity of retinal pigment epithelium. So what's the most likely concomitant systemic condition? Lymphoma, melanoma, vasculitis, or Kaposi sarcoma? So it was melanoma. Here we present a summary of the course of the disease. In 2016 April, she had the excision of naivus in the back, and it was cutaneous melanoma. Then she had the excision of metastasis in axillary lymph nodes twice. From 2018 January to April, she was treated with interferon alpha, as I mentioned before, and in April she felt worsening of the visual acuity of the left eye. In June, metastases were found in the neck and spleen, and she started treatment with vemurafenib and cobimetinib. Once again, the picture of the fundus and OCT view after the chemotherapy, and we see no promination. Which of the following diagnostic methods of an eye would you do first? OCT, ultrasound, or fluorescence angiography? And it's also as ultrasound. Which ultrasound view was expected to be seen in this case? Please pay attention to the information in the text. Option A, in B scan, dome shaped lesion. In A scan, the tumor surface spike is high, followed by quickly decreasing amplitude in the tumor until the scleral spike. Option B, in B scan, acoustic features similar to adjacent choroid. In A scan, high internal reflectivity. Option C, in B scan, medium to high reflectivity. In A scan, moderate variable amplitude of spike following the high amplitude of the tumor surface. And it was C. That's the ultrasound view of our patient. OCT was also performed, and irregular lumpy-bumpy anterior surface of the lesion was observed, which was associated with subretinal fluid. After 1 year in CT, subcutaneous armpit metastases were detected. In MRI, multiple brain metastases, and the patient complained of worsening visual acuity of the left eye. The right eye is without any significant pathological changes. The visual acuity of the left eye is 0.5. Intraocular pressure is in the normal ranges. Media is clear. Brown-gray, irregular pigmented, elevated choroidal lesion in the macula with associated retinal detachment was observed, and it was in the same place as 1 year ago. In OCT, serous retinal detachment in the macula. So she was prescribed with nivolumab by her oncologist. She came back 1 month after, and the visual acuity was getting worse even with systemic treatment. It's 0.4. Promination and retinal detachment in the left eye persisted, so the patient continued with treatment. What's the diagnosis? A, choroidal metastasis, B, hemangioma, or C, choroidal melanoma. So based on the anamnesis, cutaneous melanoma, objective findings, ultrasound and OCT views, which I have showed, the diagnosis is choroidal metastasis associated with cutaneous melanoma. And here you can see the picture of left eye fundus and OCT view from the first patient's visit to ophthalmology department. And literature review shortly. Choroid is the most common ocular site for metastatic spread. Skin is one of the least frequent sites of primary tumors associated with choroidal metastasis. Ocular involvement was found in a third of patients who died from metastatic cutaneous melanoma. The differential diagnosis is very challenging, and anamnesis is one of the most important parts of the patient's examination. If we have a history of cutaneous melanoma, then probably we will have choroidal metastasis. And if there is no history of cutaneous melanoma, probably it will be choroidal melanoma. Choroidal metastases grow more rapidly and are more aggressive, while choroidal melanomas grow relatively slower. And choroidal metastases are observed in younger patients. Appearance is also very challenging because they can look sometimes very similar. However, more often choroidal metastases are flat or plateau-shaped with large infiltration, dark brown color. Some of them have orange lipofuscin pigment at the surface mimicking choroidal melanomas, or they can have dark pigment patches resembling leopard skin. So in the left two pictures, we can see choroidal metastasis, and in the right ones, we can see choroidal melanomas that are more solitary or dome-shaped with nodular configuration. They can also have orange pigment. Ultrasound is one of the most important diagnostic methods. In choroidal metastasis, we have higher reflectivity on A scan. They appear equidense on B scan, and they have significantly lower height to base ratio compared to melanomas. OCT can give us the view of irregular or lumpy bump anterior surface of a lesion in choroidal metastasis. They are in A1 and in A2 pictures. Also, we can see subretinal fluid. However, subretinal fluid can be also found in choroidal melanomas. And choroidal melanomas have smooth dome anterior surface of the lesion is presented in the picture E. It also have outer retinal alterations and changes in retinal pigment epithelium. And picture C is hemangioma. So thank you for your attention.